I'm sure that all of us have had heinous things said to us by patients when they're not happy with us, and continued sort of rolling with the punches. And it really gave me pause and made me sort of have to stop and step out of the room in a way that I don't usually have to do. And obviously I still remember it. It sucked. It really sucked.
Welcome to another episode of Shrinking Burnout. I'm Andy, and on today's episode, we're going to take a deeper dive into the intersection of clinician burnout and sexual minority identifying providers. We'll take a brief look at the literature, and we're bringing on two special guests to discuss this with us today.
Hi everyone, it's Varsha here, and welcome to Shrinking Burnout. So today we have two guests who we know very closely and very well. They're both residents in our residency program. We have Austin and Sam, and they're here today to tell us a little bit more about their experiences.
Thank you for having us.
Yeah, thanks for having us.
Austin and Sam, why don't you tell the audience a little bit more about yourselves and your experiences?
My name's Austin. I am a fourth-year psychiatry resident in the same program as Andy and Varsha. I am applying right now to do child and adolescent psychiatry, and I have a specific interest in working with sexuality and gender minority youth. I've done some research in the field of gender minority youth, and I also have worked with LGBTQ patients in psychiatry. And I am originally from Texas, and I identify as a gay, cisgendered white man.
I'm Sam. I'm a fourth-year psychiatry resident at Bethesda Deaconess Medical Center. I identify as a queer man, somewhere on the spectrum between non-binary and cisgender man. And I have an interest in outpatient psychiatry and working with LGBTQIA populations, including transgender patients. I've done some work in transgender cultural competency and medical education, and I'm excited to be here today.
Well, Austin and Sam, we're happy to have you here. One of the things we talked about in prior episodes is how the causal factors leading to clinician burnout can be very individualized, and that the best way to better understand these factors is to really hear about and understand personal clinician experiences. I'm really curious to hear about your experiences being LGBTQ providers, and also hear about your experiences working with the LGBTQ population.
But first, I think it would be really helpful for us to talk briefly about the literature. So there isn't actually that much written in the literature, but I did find an article comparing the mental health and well-being of LGBTQIA medical students to those of heterosexual medical students. There was a study done at the University of Minnesota, and they surveyed 4,763 students in 2010 to measure depression, anxiety, self-rated health, and social stressors.
So what they found was that compared to heterosexual medical students, LGBTQ medical students had about 1.5 times the rate of depressive symptoms, anxiety symptoms, and low self-rated health. LGBTQ students were also more likely to report social stressors, including harassment and isolation.
Now, one of the first questions I have for you guys is, we see with this study that there are higher rates of depressive symptoms and anxiety symptoms, but is this something that is necessarily just limited to the medical student population or the clinician population, or is this something that we also see in the general population?
But to put this research into context, LGBTQ individuals are more than twice as likely as heterosexual cisgender men and women to have a mental health disorder in their lifetime. And in my own work, I see higher rates of depression, anxiety, and substance use disorders in many of my LGBTQ patients.
So what I think is, or at least very important to acknowledge here, is that students who are coming in with LGBTQ identity and background may already be coming in with a history of these mental health disorders as a result of just very complicated psychosocial stressors. And so when you think about what these medical students may have been facing before even joining medical school versus after, I think that's also an important factor to acknowledge. And I know some of these statistics aren't necessarily inclusive of that level of specificity.
Yeah, and Varsha, I think what essentially you're saying is that LGBTQ medical students may already have had prior histories or episodes of depression or anxiety, and that this is not necessarily, but it could be just translated to this time in their lives where they're at increased risk of becoming more stressed and becoming more burnt out just by the nature of their work as medical students.
Plus, I think it's important to recognize that as LGBTQ medical students, or at least when I was a medical student, there's a sense of having to do even better than your straight or cisgender colleagues because you are of a minority population. I might have been like one of the only few gay guys in my medical school. And so to not be successful or to do well would sort of look worse on me than maybe someone that isn't gay. So I think that having to strive for doing even better than your colleagues can really lead to a lot of stress and depression and anxiety like we're seeing in this study.
And Austin, that's definitely really important to bring up because I do think that it's not a unique experience for minorities, across the board. I think what's important to acknowledge is that when one of our other past podcast episodes where we discussed specifically racial minorities in medicine, we were also discussing how there feels like there needs to be some kind of a motivation to almost prove yourself or do better than those around you to get some kind of equal recognition and respect. So what sorts of unique issues do LGBTQ identifying providers face that may be contributing to higher rates of clinician burnout?
Were you trying to represent all of the gay medical students? Were you concerned that you were just going to make all of the gay medical students look bad if you didn't do well?
I mean, I think it's one part like an internalized sense that other people are looking harder at you, whether or not that's true. And I think it's another part of people actually looking at you differently because you identify as something different from maybe what they identify as or is what they usually see. I don't think I knew anybody in my medical school in like the higher administration or leadership positions that were gay. So I don't know that my faculty or my attendings really had a lot of models as to what a gay physician looked like or could be like. So I think it's an amalgamation of our own internal sense of having to do better, but also our attendings and teachers' senses of not really knowing what our lives are like and what we could achieve.
You mentioned a few things that are really worth fleshing out, including the overall lack of representation in terms of faculty that look like you identify similarly, and maybe at some points you felt unfairly pigeonholed into a role that you felt may not necessarily be something that you're comfortable representing. And I can imagine that must have felt really, really difficult. So that leads to my next question, which, Austin, how was it being a gay medical student in Texas?
I was out in West Texas, rural Texas. Just to paint a picture of Texas, there's very different parts of Texas. There's urban areas of Texas that are probably not that different than most urban areas elsewhere in the country. And then there are parts of Texas that are out in the middle of nowhere and they look very different than other parts of the country, like definitely different than Boston. I was in medical school out in West rural Texas, where I didn't know many other gay people at all where I was living. So I think it's tough at times. I think mostly just because people weren't exposed very often to people like me. And I think to speak to some of maybe what's contributing to these rates of depression and anxiety that we see, I don't know how many people felt safe being out at my medical school. I later found out about classmates of mine that actually do identify as gay that weren't openly gay during medical school, probably because they felt like they couldn't be. So it's very different being gay in Texas, depending on which part of Texas you're in. And I think a lot of times people probably don't feel safe being open about it.
Yeah, when I think of the word closeted, it just sounds like a really unsafe place to be in. I don't feel safe being in a closet. And I would imagine that closeted individuals also similarly don't feel safe just really being themselves or just, behaving like they normally would want to behave just in the real world.
Austin, thank you for sharing that experience. I think it's very striking to me in particular, that feeling of otherness that you described, feeling that you almost have to be private, secretive about who you really are. Were there any instances in medical school where you didn't feel safe because of discrimination, harassment, situations that made you feel like you were almost in danger as a medical professional where you were at?
I think I was fortunate where I was at school. I think most of the pressure where I was going to school was probably more implicit and maybe in the realm of like microaggressions rather than discrete harassment. I never faced any like explicit harassment for my sexuality, but I do know that there were times in which I maybe was out in other parts of the town, maybe at a bar, and there would be sort of hushed things said about me or when I was out with like my partner. But during medical school, I actually was very lucky that I didn't face any overt discrimination, at least not that I was aware of. And I think that's the thing is sometimes you don't know if people are holding you in a different esteem because of your sexuality. Sometimes you can only wonder and speculate whether or not someone is changing their opinion of you based on you being out and open. I think a lot of times maybe that's happening and we don't know about it.
As Austin was talking about his experience growing up in Texas, I was also thinking about how myself growing up in California also isn't all one place or one demographic. And I'm from a more rural, conservative part of California. And one of my memories of being exposed to medicine was the town pediatrician. And I remember as a teenager who was starting to become aware of being attracted to men, part of me feeling hopeful that I may be able to trust in my doctor to get advice on this part of myself that I had no way of understanding, that was very threatening to me, that I didn't really have any adults who I could turn to about it or peers. And she asked me if I was dating any girls. And she was a really, in many ways, a very wonderful pediatrician, very kind. But when she asked me that, I felt like that opportunity to trust in someone was closed off to me. And I think that is part of why it's so important that we are visible and we are out as queer providers. And I think it's also why it's important for us to talk to other providers and let them know about our experiences so that they are maybe not making an assumption the next time they talk to a young patient.
Absolutely. I think it's so important that as providers, we also learn how to do a comprehensive sexual history, and that do not be afraid to ask questions that may feel uncomfortable or maybe a little bit out of your comfort zone. I remember my pediatrician in particular used to be very afraid actually of asking any question related to sexual health. And so it was actually incredibly uncomfortable when she would ask me any kind of questions about if I was dating anyone, whether I was sexually active. There was a lot of judgment. And that can very severely, I think, influence a patient's decision to really seek medical care later on in their life, and can very seriously detract from a person's ability to trust in medical professionals.
Well, when I was in medical school, I was in an inpatient rotation and was working with a patient who had influenza A and another patient had active tuberculosis. And around this time, I developed a severe respiratory illness and went to the doctor to get a diagnosis and treatment for it, in part due to rule out tuberculosis. And one of the first statements that he made was, well, I don't want to scare you, but this can be how HIV presents for the first time. And he hadn't asked me about my risk factors. The only reason to me it seemed that he was asking was that he knew that I identified as a queer man, but he had no idea as to what my other risk factors would be. And in fact, I was in a monogamous relationship with a HIV negative partner at the time. And so that was another experience where I think heterosexism was at play.
When you think about it, that's awful. I feel like you're legitimately, I'm sure, thinking of that provider, maybe they were trying to, I guess, get a better medical history or whatever it is. But I mean, they're essentially frightening you and scaring you at that point without really having any more information about the situations. And I'm sure that experience was also not unique.
And Sam, the examples that you provided really paint a really important picture for clinicians to be able to be more aware of any sort of possible microaggressions that they may be saying whenever they see their patients, or even whenever they talk to their colleagues who are also providers, in the form of really thinking about how certain things that you would say are unnecessarily heteronormative, or they may be discriminatory to people that aren't heterosexual. I want to just kind of transition to some of the issues that LGBT identifying providers face that possibly could be contributing to higher rates of clinician burnout?
In addition to Andy's question, I would like to also invite you both to discuss patient aggression and discrimination towards providers in the work setting. We often sweep these particular microaggressions or discriminatory remarks under the rug because we're taught to just sort of deal with it, it's part of the job. The whole idea that we have to maintain professionalism above everything else. But I think it's extremely important and incredibly salient to what we're talking about together today. Definitely can contribute to burnout. It can be painful to work with someone who's harassing you, is insulting or discriminatory. Has that ever happened to either of you here in Boston or in prior work environments?
I actually never had any instances of it in Texas, which I think is important to say. That despite me going to medical school out in rural West Texas, I didn't face overt aggression from patients in the same way that I've actually experienced in Boston. Granted, I'm seeing a different patient population maybe than I was seeing in medical school, dealing with different problems maybe than patients I was typically seeing in medical school. But still, I think it's important to highlight that like this can happen anywhere, regardless of what the city's reputation is or like what the general population stance is. I think that people, when they're not doing well, will find a way to take it down a notch. And I think that the times I've had it happen were with really sick patients. And so like, I think it's important to acknowledge that first off, there are people that are not doing well. And at the same time, like it still sucks. And it was during my second year when we were on call a lot overnight, and it's already really tough being awake for 24 hours. So to throw on top of that, there was a time when I was on call overnight. Inevitably, the worst things happen when you're on call overnight. And I was seeing a woman that was not happy to be in the emergency room and not happy to be seen by me and not happy with the decisions I was making around her next steps of care. And she was likely manic and not really doing her best. And at the same time, we had been able to have a mostly okay conversation for quite some time. But at some point, when specifically discussing my recommendations, specifically talking about her likely needing to stay in the hospital, she became really angry with me. And even though I've not sort of disclosed anything about myself or what I do outside of the hospital, she called me a faggot and used that as a way to like express how angry she was with me. And it really paused me. I'm sure that all of us have had heinous things said to us by patients when they're not happy with us and continued sort of rolling with the punches. And it really like gave me pause and made me sort of have to stop and step out of the room in a way that I don't usually have to do. And obviously I still remember it. It sucked. It really sucked.
And Austin, I think one of the things that you really mentioned that really causes a lot of distress in clinicians is that when there's a patient in which your job and your duty and whatever responsibility you have as a doctor is to really care for the patient, and you're trying to do something for the best interest of the patient, and all the while the patient may be really saying a lot of potentially hateful, homophobic things, and you can't really say too much, right? If it were a regular interaction, maybe you were out on the street, maybe you could say something back to them, or maybe you could just like walk away. But here you are as a doctor and you have a patient that's saying terrible, terrible things to you, and you can't really do much. And I think that's sort of when you start to feel a little bit more of that stress and a little bit more of that burnout.
We still have to do our best to help patients even when they're homophobic. I remember a patient who was seeking support for depression who I was asked to see, and she was reporting the source of her depression was that her daughter had come out to her as a lesbian, and that she was so upset that her daughter could do this to her. And I sat with her and supported her. And there's a tricky balance there about recognizing the affect that is real while distancing yourself from attitudes and beliefs that may be hurtful or that you disagree with or that cause you discomfort as a provider.
And in those moments, Austin and Sam, what was able to help you through those moments? Because those are very painful and uncomfortable, distressing examples that you both gave, and they're certainly not unique. So what helps to get through those periods when you are facing harassment, discrimination, homophobic statements from patients?
This is sort of an aside to your question, Barsha, but do you remember actually this happened once when I was on shift with you as a Twilight? Do you remember this?
Remind me.
It was a patient that it's not the patient I just told about, another patient who also did this to me that I saw.
Tell us.
I mean, so basically by answering your question, part of it is like getting support from my co-residents and like my coworkers. I think I had another instance where a very angry man who was also inebriated in the emergency room that I tried to see, who was not really up for talking to me. And sometimes when patients don't want to talk to us, we still give a good effort to trying to coax them into having a conversation with us, because as psychiatrists, our ability to understand what's going on with the patient usually involves a conversation with them. And as I continued to try to engage this man in a conversation, he was getting increasingly upset with my efforts to do that, and eventually ended up saying, like, fucking faggot, like, can't you just get out of my face or something like that. And I remember just coming back to the workroom, where I was fortunate to have coworkers on shift with me that I was able to sort of talk to about what just happened.
Varsha, do you not remember giving support to Austin?
I just, so freely give support. It's so hard to remember every single time.
Well, what I also remember too is like sometimes when we're working with other people, like there's this sense of someone has to do the work sometimes, and it could have been someone else that had to go talk to this patient, but it was me. And I think sometimes there's a sense of feeling responsible for having set your coworker up for this terrible thing, which just isn't true. It's just kind of like bad luck, basically. But having the support of my coworkers who have had probably, unfortunately, similar experiences with patients was really helpful.
And I think you're hitting a very important point in that the people you work with make all the difference. I think it's so important to also feel safe and respected with your colleagues and the particular group that you're in. The hospital culture and climate, I think all of those are very important aspects to also, I think, building resilience and decreasing the likelihood of burnout. One thing that makes it especially very difficult is, I've definitely, for example, we all have had times where we're alone in the emergency room and, no one else is really working with you at that point in time. Maybe it's 3 a.m. and you have a patient who comes in who really gets under your skin. And it's hard. In those moments, you can feel really alone. But I think the important thing is being able to still feel safe and comfortable enough to maybe call up the person who's on as a backup that night and talk to them about how you're feeling. Talk to the first year resident who's on. I think the most important aspect is being able to feel comfortable enough to do that if you really need to reach out. And I feel fortunate in that case.
I feel incredibly supported by my colleagues. And I know that when I've had a difficult experience, including being called the F word, that I have people who I can turn to for support or humor or distraction pretty much at any time of night if necessary.
I think it's important to acknowledge, though, being able to use your colleagues for support in this way requires that you feel safe being out with them. Because I think if I wasn't out in the workplace, I don't know if I would be able to give this anecdote of what just happened with this patient in the full sense of what happened if I wasn't out. It would be really confusing as to why this patient was calling me the F word if my colleagues didn't know that I was a gay man. And so I think getting to be able to get that full sense of support requires that you feel safe being open and honest with your colleagues, which isn't always the case.
Absolutely. So I'm curious to hear, Austin and Sam, whether you've actually had very welcoming and positive experiences with respect to identifying as an LGBTQ provider.
I feel like due to my identity, I'm able to help patients feel more comfortable with their own identities and with coming to me with things that either may or may not be related to gender and sexuality. I work at Fenway. I work with a variety of folks in the LGBTQ community. And I found it incredibly rewarding to work with gay, transgender patients who feel more comfortable talking to me about what they're dealing with, whether it's related to gender and sexuality or not. And I feel fortunate that I'm able to do the work that I do with these populations.
I also think, at least I feel lucky to have ended up where I've ended up for my training. I think that I've had the opportunity in residency to work with very supportive and understanding faculty and attendings that I maybe didn't have the experience working with in medical school. I think I've had almost the opposite end of the spectrum of an experience here, where maybe in Texas, if I'm talking to a colleague or a teacher, maybe they meet my boyfriend and they ask oh, who's your friend? Or they'll reference my boyfriend as my friend. Whereas here, everyone refers to my not husband, but boyfriend as my husband. It's the other end of the assumption where They're so okay with the idea that they just assume that I'm already married to a man. It leaves with a very different feeling. I think it really does matter when the people that are higher up than you in the organization, especially in medicine, which is very hierarchical, that there is explicit support around the relationships that you're in and the people who are important to you. So I think every time one of the program directors asks about my partner, it makes me feel really welcome and like I'm part of the family, which isn't something I had before.
It makes you feel seen and valued. And I think about it in contrast to maybe some experiences I had early in medical school, where I really found it difficult to connect with some of the heterosexual male mentors. And I'm not sure to what extent it was my own discomfort versus theirs. I suspect more of the latter. And I've found that in residency, that's not the case at all. And that I feel fully supported.
Let's make a quick segue into talking about how we can make our profession as a whole more welcoming for LGBTQ providers and some tangible ways in which we can really improve the environment.
I actually have one particular story that ties to this. So we did have a patient when I was a first-year resident, and the patient identified as a transgender individual using the pronoun there. What happened was that the patient, through using a pronoun that many of the older, maybe faculty, staff, were not used to using or not as comfortable using, it was more so the former, just not so used to it, or sometimes forgetting or misgendering the patient. This led to the patient feeling frequently re-traumatized. And this happened multiple times, and it ended up actually opening up a discussion about how we need to better educate ourselves on also increasing our level of comfort and understanding of the trauma that can occur from misgendering an individual, and how important it is that if we're presenting ourselves as allies and creating a safe space, that we have to be aware that, that we need to continue to educate ourselves, really. And I think that what was really important and also very eye-opening for me was that a lot of the younger staff members were more understanding and able to modify and change the way that they were both utilizing pronouns and also the way that they were introducing themselves with their own pronouns to patients, whereas some of the older staff members had a lot of difficulty doing so. But I think the exciting thing about medicine in general is that there's constantly new people coming in and both young people who want to change and want to make things different, slowly changing the culture of institutions from within. And that was really what I was able to see firsthand.
And Varsha, to really add on to what you were saying, this was a level of change that was directed with patient care in mind. But I think it's also important for us as non-LGBT providers to understand that we also need to be able to use the correct pronouns and not to misgender our colleagues who are not heterosexual identifying either. And I think that's also something that we have to carry in the future as well.
I think that's a good point, Andy, because I think something that also Varsha's story illustrates is, imagine if you were a resident who identifies as trans or gender non-binary, and you hear the staff struggling in this way around a patient's pronouns. It can make you feel really unsafe working in an environment like that. Because, if they're doing that with the patient, what keeps them from doing that with you? And I think that dovetails well with something Sam and I were talking about earlier, which is, I can only speak from my own experience, but I'm a gay white man. And so I recognize in the LGBTQ community, there's a certain amount of privilege that comes with. And while what I've gone through as a gay provider is tough, it's probably much tougher for those in the trans community that are in the medical field. And so taking whatever privilege we have and trying to stand up and be an ally for those in the community that have less power in the system is really important.
Yeah, I think that change begins with trying to extend your own experience and learn from other people's experiences. For myself, my journey around learning more about transgender healthcare was in medical school. We had started to learn about some of the medical aspects of gender-affirming treatment, but I was struck by the fact that psychosocial determinants of health play such a role in transgender individuals having higher rates of illness, of dying earlier in life, of experiencing abuse and trauma. And I had felt like we weren't talking about that side of their treatment, which was clearly very important to their health. And so my classmate and I joined a support group of trans individuals, trans homeless women specifically, and asked about the types of experiences that they had had in healthcare. From that, came back to our class and developed a curriculum that was incorporated and included moving forward. And so I think it's important to start by recognizing what we don't know, and then by learning about other people's experiences and reaching a hand out.
And in my medical school specifically, I actually had a similar experience, an opportunity to help assist with curriculum development, specifically trying to increase the amount of education that we as providers, or at least medical students, were receiving about LGBTQ healthcare. And one thing that I was able to get involved in was both a human sexuality and medicine lecture series, where we did have different providers from different institutions come in to talk a little bit more about the specific mental health conditions that you described related to trauma, PTSD, substance abuse, depression, anxiety, you name it. And what was very surprising to me was actually that a lot of the other students that I had worked with actually had never really learned or felt like they had learned much or had much of an opportunity to learn about these many different mental health problems that our patients face and how deeply they're intertwined with the rest of their medical care. And the other thing that I thought was really helpful, just as an example, there was also a course offered through the American Medical Students Association, basically for sexual health. And one of the things that we did do was do case-based practice, where we pretended to be either a patient coming in to an OB's office, or particular kinds of cases or scenarios where a patient might face harassment, and what you would do in that situation, where a patient may have faced harassment from another colleague or a staff member. How do you deal with it in that particular scenario? What can you do to be an ally and help make that patient feel comfortable to return? Because as we were all saying before, is that one negative experience with the medical system can really drastically affect an individual's desire to want to seek medical care in the future. And so that was actually, I found, really helpful, and I think is something that we could try to incorporate a little bit more within medical education, more case-based learning, examples, and practice, having, often difficult conversations with people related to sexual health or gender and sexual identity.
Well, there was one thought I had based on the story that Varsha just told relating to those cases. I think as medical doctors, it's very easy for us to think about medical doctors. And I think a lot of times the harassment or microaggressions or just general tension our patients might face oftentimes isn't with the doctors. Like, it can be with any parts of the system. And so I think it's also important we recognize that the staff in the waiting room are incredibly important in making a patient feel safe and welcome. And nurses are incredibly important in helping make that environment feel safe. Like, if we stop at just educating doctors, like, it won't be enough to really make that big of a difference. And so I think it's important that it's a full system that has to think about this, and not just us.
Likewise, I think since many of the challenges that we've described are related to inequalities and injustices in our society at large, I think there's a role for us to play in advocating for more systemic changes.
On that note, on systemic change, thank you so much to Austin and Sam for being here today with us on Shrinking Burnout. We learned so much about your personal experiences coping with discrimination, along with your positive experiences on patient interactions as LGBTQ providers. I think we all can say we've learned quite a bit, and we hope that we can all continue to work together to help elicit greater systemic change.
Thank you for having us.
Thank you.
As always, if you have suggestions, comments, questions, or are interested in being featured on the podcast, please email us at shrinkingburnout@gmail.com and follow us at Shrinking Burnout on Instagram. Your anonymity and privacy is important to us, and we will do what we can to protect your identity.
Shrinking Burnout is a podcast focused on furthering the discussion of clinician burnout. The views and opinions expressed in this podcast are solely our own and do not reflect that of our medical institution.